Hello, Empowers program. I'm back with the 9th installment of my clinical apprenticeship series. Today we had probably my most in-depth workup yet. And I'll get right into it because it's a long one, so I'm going to try to keep it short, but there's a lot of details. So it was a 67-year-old male who came in for roughly 2 weeks, a week and a half to 2 weeks of shortness of breath, particularly on exertion. So if he was getting around and moving at all, he was noticeably short of breath. Another word for it would be dyspnea on exertion, or DOE. And he said it's been progressively worsening to the point where he'll just take his trash can out to the end of the driveway, and he'll have to pause and kind of lean on his trash can just to catch his breath again. And he said this is really abnormal for him. He's generally a pretty active guy, and when he came in, he was actually only reading 83% on his O2 sats, which is just read by a little thing you put around your finger. It just reads the amount of hemoglobin in your blood that's saturated with oxygen. So that was right when he walked in, he was at 83%, which the normal level that we are okay with is typically 94% and above. Ideally, you're at 100% of your hemoglobin. 90 to 94 is kind of a gray area, and then generally anything below 90 is pretty concerning unless there's a good reason for it, like a pre-existing condition. So 83 was definitely concerning. The nurse rechecked it when he got kind of sat down and he was a little more relaxed. He got up to 88%, and then throughout our visit he climbed up for the most part he was in the mid 90s. But had he not improved when he sat down, we would have definitely gotten him on oxygen, because that low of a value is definitely concerning. And so a little bit of his history, he got the second dose of the COVID vaccine about a week and a half to 2 weeks ago. Not that we didn't think that this was a side effect necessarily of the vaccine, but it's just kind of a notable thing. His wife also mentioned that he seems to get anxious when he feels the shortness of breath come on, and then that seems to only exacerbate and kind of push his shortness of breath even further. And he also noted some when he is moving, going upstairs or even just walking, he notes some burning in his bilateral legs. Both legs, it just felt like they were burning. He said not necessarily pain, but just kind of some soreness, I guess. He hasn't tried much for it. He said they bought a over-the-counter inhaler, and he didn't know the name of it offhand. But he tried that and it didn't improve it at all. He didn't have any hardconditions previously, or any stents put in, or cabbage, or valve replacements, nothing like that. His family history was relatively benign as well. So on exam, he was definitely a little pale. He looked a little bit sweaty. He had some trace crackles that we could hear in his right lower lung field. And then he was clearly just kind of anxious. He was almost kind of stuttering his words, which he said wasn't normal for him. And his wife confirmed that. And then he was also just kind of tremulous, just kind of a little shaky. Our differentials, we definitely considered a congestive heart failure, a COPD exacerbation. A pulmonary embolism was definitely at the top of our list as well, and also COVID. And we also were worried about maybe he suffered kind of a silent heart attack, and this was kind of the after effects of his damaged myocardium, and just the heart's not pumping as well because it already had the infarct. So that was kind of our differential. He didn't have any notable leg swelling, so that kind of decreased the chances of a CHF, and no history of COPD in the past, so that I don't know if that wasn't very likely either. No calf pain or anything of note in the recent history, but that certainly doesn't rule out PE by any means. So we ordered the full gamut on him. We debated just sending him straight to the ER, but ultimately we just decided to kind of work him up here at the clinic, do what we could, see if we could figure it out with an EKG, with the chest x-ray, and some more general labs. We did a CBC, a CMP, a COVID antibody test, a D-dimer, which is one of the keys that we were waiting for, and then a BNP. Recent EKG previous was in 2019, so about 2 years ago. On this EKG, his T waves had flipped, changes in his R wave progression, but he had no signs of current ST elevation. But those previous two findings, the T-wave flipping and the change in the R-wave progression, could signify that he possibly suffered kind of a silent infarct. Chest x-ray found it was relatively clear. There wasn't like any significant lung disease noted or anything. There was an enlarged cardiac silhouette. Basically what that means is just on the chest x-ray, it was a little bit like the outline of the heart and the pericardium was a little bit bigger than previous or bigger than expected, which could point to a little bit of swelling, like myocarditis, or some other things that you can commonly see after suffering like an infarct or even like a pericardial effusion as well. And we didn't get the D-dimer back by the time I left. The test takes a little bit longer, but the CBC didn't show like extreme decrease in hemoglobin, which would signify maybe anemia, which could be another differential diagnosis. So we can kind of rule that out for the main cause at least. And then, like I said, we're waiting on the D-dimer to come back, but the D-dimer is just a good negative predictive value. So what that means is if it comes back negative, like in a normal level, that means that you likely don't have a clotting etiology like a pulmonary embolism. Another thing you can use for PE is the Weils criteria, and I'll include that somewhere, probably right here or something. But that was something my preceptor brought up, and that's a good way to kind of quickly go through and grade how likely it is that a PE is or has occurred. Ultimately, we decided to send him to the ER since we didn't find anything obvious, and also just because at the clinic we're kind of limited on what we can provide as far as tests go. They could either do an echocardiogram, which would have been something we could do in the clinic, but it's a little bit longer. We thought it might be better if he was just in the ED for that. And then also a CT scan, which is a little bit clearer. Look at the chest cavity just to try to get a better idea of what maybe has gone wrong. So that sums it up. I went a little bit long, but like I said, it was a really complicated patient and a long workup. And I think the patient was there for a couple hours at our clinic, which is unusual. Usually they're only there for 30 minutes at most, 45 minutes maybe. So I hope you guys enjoyed. I hope this was informative, maybe a little bit. And it certainly was for me. I definitely learned a lot. So thanks for watching, and I will see you guys on the platform.